Welcome everyone. Welcome to this hour-long event, a new standard for wound care digital strategies for relieving the burden of wounds. I'll be chairing this discussion, and I'm Margaret Kitchen, for people that don't know me. I'm Regional Chief Nurse for North Eastern Yorkshire. I work for NHS England and NHS Improvement. I'm also a practicing tissue viability nurse, and I head up the National Wound Care Strategy programme for the country. Today we're going to be exploring wound care and digital strategies for relieving the burden of wounds. We're going to hear from 4 leading voices on wound care in the UK and examine how digital strategies will be instrumental in addressing the burden of wounds to the NHS and also improving patient outcomes. We'll have a short amount of time for each speaker to ask questions. You can do this by placing them in the chat box. A reply will be sent around after the event if we've not managed to answer all the questions. We have a great turnout today, and we do want to make this as interactive as possible, so please use the chat box. We'll be endeavouring to get the answers to all the questions as we go through the event and also post the event. This is a very timely conversation. We know the burden of wounds to the NHS and society as a whole is huge. Newest studies cement what we're finding in clinical practice. We have a strategy in place, although COVID has delayed the elements of it, but we're now moving into action. Digital innovation within wound care is a key part of next steps and what will make the strategy successful. I can't see the. We're opening the introduction. The agenda we're on the programme. Can't see it up. Rob. Oh, it's there. Thanks, Rob. So the agenda today, as you can see, we're going to be very swift. Our speakers will keep to time because they've been pre-warned on that, and we will try and endeavour to get to you to questions that you're asking. And there'll be a little bit of time at the end for questions and answers also. So I like to move now and introduce our first guest, which is Julian. Julian's going to begin our conversation. He is Professor Julian Guest, Principal at Catalyst Consultant. His recent update to the Burden of Wounds study, which were first published in 2012-13 and revisited in 2020, outlines the importance of the conversation today. So I'd like to introduce Julian, our Professor of Healthcare Economics, King's College London. Julian, I'll hand over to you. Thank you.
Thank you very much, Margaret. So at the end of last year, we published an update to our Burden of Wounds study in the BMJ Open, and I think you can download the file from the file section. And this really summarised the burden of wounds to the UK's NHS in 2017-18 and looked at what had happened or what had changed since our initial analysis that focused on 2012-13. So the analysis found that the UK's NHS managed 3.8 million patients with a wound in 2017-18, which equates to in the order of 7% of the adult population. This represents a 71% increase in the annual prevalence of wounds since 2012-13 and equates to an 11% increase per annum year on year. The distribution of wounds between the two periods is remarkably similar, with the exception that the percentage of unspecified leg ulcers has decreased, and the percentage of unspecified wounds, so these are patients with a wound with no diagnosis in their patient's records, that has marginally increased, so that when you compare the two periods, 5 years ago we had just over 30% of patients with a wound that hadn't been differentially diagnosed, and that's been reduced to 25%. But by and large, the percentage of the wounds accounting for the whole room is remarkably similar. So over the 5-year period, healing has improved in the order of 13 to 14%, and that applies to both acute wounds and chronic wounds. But on an annual basis, that represents an annual increase in healing in the data set of wounds that we had of 2.3 to 2.5% per annum year on year. And we found that the presence of an infection or a definite or a suspected infection had negligible effect on the healing rates of acute wounds, but did impact on the healing of chronic wounds. You can see here it's been reduced from 59% in wounds where there's no evidence of infection to 45%. So then we looked at the percentage of patients that were using a resource. Now this graph is not summarizing the actual amount of resource that was used. That level of detail can be found in our publication. This just shows you the percentage of patients accessing a resource. And what you find is that if you compare the two periods, the front row is 2012-13 and the rear row is 2017-18, you can see that there's been an increase in the percentage of patients accessing or being seen by practice nurse visits, GPs, and receiving drug prescriptions for their wounds. In addition, there's been an increase in the percentage of patients being seen by healthcare assistants for their wounds. But there was a substantial decrease, a significant decrease in the percentage of patients being seen by district nurse visits from 73% to 38% in the latest period. And that may be a reflection of the decrease in the number of district nurse visits who have actually been employed in the NHS, or the decrease in employment during this period. We also see a decrease in the percentage of patients accessing secondary care. There's a reduction in hospital outpatient visits and a reduction in hospital admissions. But there is an increase in the percentage of patients attending A&E for their wound. As I say, the actual level of resources can be found in the PDF publication. So then, since publication of our study, I have been asked for a piece of information which was omitted from the publication, unfortunately, and that was the length of time that patients had their wound. And I have now included this in a new article that's just been published in Wounds UK. We found that in our data set, the length of time that a patient had an acute wound from wound onset until the time it healed was 1 month for an acute wound and a mean of 4 months for a chronic wound. But more importantly, the mean time from onset until the data was cut and we received the data for patients whose wounds did not heal was 9 months for acute wounds and 32 months for chronic wounds. So just to summarize, if an acute wound healed, it seemed to heal within a month. But if it hadn't healed, in our data set, the patients had it for 9 months. Now, we don't know if after the data was cut, the acute wound healed on the following day. But what we can say is that the unhealed wounds patients had was a mean of 9 months. And the same argument applies to the chronic wounds, 32 months for the wounds that did not heal. So the cost of managing the wounds increased in real terms by 48% between 2012-13 and 2017-18. So that, according to our estimate, the NHS was incurring an expenditure of £8.3 billion to manage 3.8 million wounds in 2017-18. And a reflection of the way that patients are accessing resources, we now find that a much larger proportion of patients being managed in the community, and therefore a large proportion of the costs are incurred in the community, and only 19% of the costs are now incurred in secondary care. So if we look, this graph really summarizes in 2017-18 prices what the NHS is spending on different conditions. And in 2012-13, the annual NHS cost of managing wounds and comorbidities at updated prices to 2017-18 is £5.6 billion. And we reported at that time that this was comparable to the cost of obesity, which is broadly similar to pricing. 5 years later, annual cost of wounds is now £8.3 billion, has overtaken that of obesity, and is approaching the combined NHS cost for managing arthritis at £10.2 billion. In parallel with the changes we've reported, we found a distribution in the age profile of the patients. 5 years ago, 2/3 of the patients were 65 years of age and younger. 5 years ago, 65% of the patients were 65 years of age and older, and in 2017, 2/3 of the patients are under 65 years of age. And what we found is that in parallel with that change in the distribution of age profile, we have a change in the comorbidities. But most importantly, 5 years ago, 29% of patients had diabetes, and now when 2/3 of the patients are under 65 years of age, the percentage of diabetes has almost doubled to 57%. I need to be quick, I'm running out of time. Very quickly, we found that 30% of the wounds in our data set remained unhealed, and they accounted for 67% of the cost. So clearly, healing a wound is going to reduce the costs incurred by the NHS and also the resources that are utilised. So just to summarise, changing the healing rate had a larger effect on resource use and costs than changing any other parameter, and improving healing rate is critical to reducing the prevalence, resource use and costs of wound care. So just to conclude, the clinical and economic benefits to patients and the NHS could accrue from strategies that focus on more accurate diagnosis, preventing infection and improving healing rates. But it's my opinion that these benefits are unlikely to be realised unless there is a structural change within the NHS in order to manage the increasing demand for wound care and improve patient outcomes. Thank you.
Thank you, Julia. Very interesting presentation. I'm just looking to the audience to see if there's any burning questions. I've just got one if I can answer, while people might want to put a question in the box. If not, we'll move on. We've got time for questions and answers at the end. But Julian, just to clarify on the charts in reference to the cost, the 8.3 billion cost, and that was charted into diabetes, etc., etc. Are we specific then that the actual wound cost, because obviously heart disease, diabetes, those long-term conditions, we have strong high prevalence of wound care issues there. So is that separated, or could there be any counting in any of that?
According to our analysis, the cost of wound care was 8.3 billion. That does not include the cost of resources required to manage heart disease or diabetes or any other comorbidity. But the possibility that there's been some conflation can't be excluded, but we've tried to focus exclusively on the cost of resources required to manage wounds.
Fabulous, thank you. I thought that might be the answer, but it's helpful, that we get the best data we can, and we can see the increasing cost, which is worrying to us nationally, worrying in terms of patient experience, and clearly the increasing long-term conditions, obesity, diabetes, which you've just demonstrated, which impacts on wound care is significant for us all. I'm going to move us on. I hope, team, I'm not missing questions. If I am, please let somebody tell me. But I'll move us on because I think the next presentation for me around the patient perspective is just as important about the evidence. And thank you, Julian. That was really, really interesting information. So our next guest has worked in England and Scotland as lead tissue viability. She graduated of the Pfizer Fellowship and co-founder of the social movement #TVNTogether. So Jenny McDonald is our lead nurse in tissue viability in Lothian. She's going to be bringing a patient perspective for the next presentation. Thank you and welcome, Jenny.
Thank you, Margaret. So just following on from Julian's presentation, I really wanted to bring the patient perspective to the discussion. Julian's really talked about the true size and the true impact of wounds on the NHS, and I just wanted to really put the patient's voice in the discussion. So people watching today who have looked after patients with wounds will be all too aware that there's a big impact to the patient's lifestyle if they have a wound. Patients suffer from loss of function and loss of productivity. Now, that might be something around struggling to manage the household, or that might be having to have days off work because of their wound, and sometimes even have to give up employment completely. So these things can have a massive impact on the patient lifestyle. Other things that we know of that wounds impact on patients in terms of restricted mobility, or at the other end of the scale, there could be excessive movement and agitation from having a wound. Patients quite often report reduced appetite, sleep disturbances, fatigue, and again, a real threat to patients is infection, bleeding, and obviously the threat of sepsis. Patients report allergic reactions, and the most common symptom reported is pain. But we have to remember that there is other things that we might not think about immediately when we think about the impact of wounds. Some patients can't wear the clothes or the footwear that they want to wear because of their wounds. And activities of daily living, even simple things that we take for granted, like bathing and showering, can become very complex for the patient with a wound. So we know that wounds reduce our patient's quality of life, and they reduce our patient's self-esteem. We do know that there's high levels of social isolation and anxiety in the wound patient population. And this is a mixture of intentional withdrawal from society and social gatherings, for example, because patients have a real embarrassment in terms of maybe wound odor. And there's a real anxiety and a real fear around potentially the patient's wound leaking in a public place. So patients will intentionally withdraw themselves away from society for the reasons I mentioned, which are confounded by the physical constraints that I've mentioned earlier in terms of mobility and physical restrictions. The patients with wounds have to think about and plan journeys. For example, taking public transport with a wound is something that really needs planned, and those without a wound can take that for granted. So there's a lot of social isolation in this population. Depression in the wound care population is 3 times higher than that of the general population. And these mental health concerns increase with the longer the time the wound remains unhealed. And obviously, the degree of the symptoms, such as odor, will have an impact on that as well. Patients who have wounds report feelings of shame, disgust, self-loathing, and loss of control. And when it comes to mental health in the wound care population, it's a bit of a chicken and egg situation in terms of, I've already said, the longer the wound remains unhealed, the higher risk of mental health concerns. However, we also know that there's a link, physiological link, with delayed wound healing in patients who have depression and anxiety. So it becomes that vicious cycle. Now, in this slide, I want to bring you Diane's story. Now, Diane's story, TVN Together, like Margaret said, the UK network of tissue viability nurses, in one of our awareness campaigns back in 2019, we brought together Diane's story, and I wanted to share a shortened version of it with you today.
My son got married 3 years last May, and when I got to bed that night, I've been in my wheelchair all 3 years last May. There was a breakdown of the skin, and before we knew it, within 4 weeks, 5 weeks, it had developed beyond recognition. It was the size of an egg, just a black hole, and it went down 13.5 centimetres. I had to go to hospital with a raging temperature and lots of antibiotics and drips, and I was in a bit of a state. Got home and was told I have to spend 20 hours a day in bed on a pressure bed to help the sore. Not only had it got huge, the odour was unbelievable. It was like rotted, well, it was rotted flesh. Hence my daughter had to come in and put these sprays that emitted a nice smell, but She couldn't even be in the room with me sometimes. It was just awful. I mean, my friends still came, but I apologised for the smell before they walked in. They were very kind. I said, oh, can't smell anything, which I knew they could. Life is very difficult at the moment for me. I'm very restricted to what I can do. But having to be told that I had to spend most of my life in bed wasn't nice. Visitors come, where are you? I'm in bed. You know, and it's just, it's awful. It's embarrassing, really. Having parties, they always have to have them here because of me, because I can't get anywhere. And they'd all be outside, you know, having fun, and I'd have to go to bed, which can be a bit devastating, really.
Thank you very much, and a big thank you again to Diane, who shared her story, and we continue to share that around our networks. It was some good news. If you want to see the whole video, it's on the TVN Together YouTube channel, and we've recently found out that Diane, after several years, is now healed. So some excellent news for those that are familiar with the story. Just before I hand back to Margaret, I just want to leave you with one point. Now, to follow on what Julian was saying around in the UK having 3.8 million wounds, I would like you to take away that that's 3.8 million patient stories, just like Diane's. And that's 3.8 million individual physical and psychological burdens on patients, on families, and their carers. Thank you.
Thank you, Jenny. Really helpful and informative presentation. I just need to apologise for people. I've only just managed to get the questions up after Julian. So there is some questions, Julian, that I want to just run by if I can. And Jenny, I think there's one for you as well. But I'll go back to Julian first if I can. And the first one from Sue Priestley. In your paper, you talk about inconsistency in wound assessment, Julian. How do you see innovation helping that?
I think anything that will give us reproducible diagnosis in terms of wound type, wound size, can only be a good thing, and digitalization, I think, can certainly help with that.
Thanks, Julian. And Kate Hancock, she's asking, could we ask if the wounds were prevented, what impact on cost would that potentially have?
If wounds were prevented and the burden didn't increase, then costs would come down and resources would be made available for alternative use within the system.
Thank you. I'm just scrolling up. There's lots of nice comments, Julian. I'm hoping you're following those. I'm trying to be speedy. I did have a question as well, Jenny, for yourself. I've just got to find it. Forgive me, because they're hopping in very quickly. I don't think I can find it. I might have to ask you next. Hang on. Somebody's helping me out here. Right, Jenny. Does this create vicious circles of depression? So obviously, in terms of the patient story, causing slower wound healing, causing depression, and so on. A question for you, Jenny.
Sorry, I didn't catch the start of that. You were talking about the slow wound healing and the depression cycle.
Yes, and you know,
about how we should be addressing that.
Yeah, and is it a vicious cycle, which I think is what you're alluding to in
it absolutely is. And you can, although, you know, it's difficult to imagine having a wound, those that have cared for patients with wounds become, you know, quite intertwined in the patient's life and how that does affect them. I think certainly we've got some improvements to do as healthcare professionals in addressing the mental health concerns caused by wounds going forward. And I think at the moment, I think we're relatively limited to signposts for mental health support, but we should be making that standard practice.
Yeah, absolutely support that and agree that. Julian, can I ask you to check the questions in the box? James Rodriguez-Hughes has put a very, very interesting question in the box, but I think it's your technical abilities here that will be helpful to it if you'll answer that for us in the box. Because I'm going to move us on now, and you'll find I'm going to need to keep doing this to just keep us moving in time, and we'll try and come back to some questions at the end if we get time. So, Jenny, thank you. Really, really interesting presentation, and thank you for bringing the patient perspective into this event today. So, moving on from that, the National Wound Care Strategy says that using a mobile wound management digital system supports a consistent approach to care and improves communication between multidisciplinary clinical teams. We're now going to hear from a team who have started their journey of digitising their wound management to try and offset the burden of wound care. So I'm introducing Laura Brown, the Operational TBN Lead from Community Services NHS Trust, which serves more than 6 million people in the East Midlands. So I'd like to introduce Laura, Critical Viability Nurse, Leicestershire Partnership NHS Trust, and she's going to give us a clinical focus in her presentation. Welcome, Laura.
Hello, good afternoon. Thank you for inviting me along today to talk to you about a trial that's obviously been taking place in our trust, in Leicestershire Partnership Trust, where we've integrated the Healthy IO digital management tool into our wound clinics. So first of all, just wanted to introduce you to some of our team who've been working on the project. So Kelly here, who's listening today, is one of our clinic nurses and has taken the role of the Healthy IO lead in the team, which has been absolutely vital, just having someone there and available for that clear line of communication for clinical support. We also have Rebecca here and Heidi, who are two of our Legalsa clinic nurses, and you'll get to hear from Heidi a little bit later on in the presentation, where she talks about her experiences of using the Healthy IO digital management tool. So a bit about our service to start with. So the clinic service that we run has 11 registered nurses. We have a clinic manager, a clinical lead, and myself, who's the operational lead for the service. And we run 10 clinics across Leicester City. So our service provision is for general wound care. So we care for patients with post-surgical wounds like sinuses, abscesses. We deal with trauma wounds, burns, and foot ulcers with the support of our podiatry service. We also run a number of Legalsa clinics caring for patients receiving compression therapy. So prior to the integration of the Healthy IO tool, we were doing manual wound measurements. So we were basically using the sterile measuring guide out of our dressing packs to measure our wounds. Obviously, naturally, this opens to the risk of inconsistency and inaccurate wound measurements being recorded. We were also getting quite poor quality images, so images that could be blurred, that might be too close to the wound, too far away, and may not have the patient identification within the image. Our organisation as well had identified that there was a delay in the photos being uploaded to the patient records. So they were sitting on the devices, which of course could have an effect on continuity of care and could delay that treatment pathway being reviewed by the registered nurses. So when Healthy IO approached us, it seemed like the ideal opportunity to address some of these concerns that we had identified. So the Healthy IO app, it allows us to capture quality images wherever we are, which the app then makes standardised and comparable. So nurses can compare one of the most recent images to the next much more easily. And this starts to create that digital journey of the wound's progression. And we've found it a really useful tool to start engaging patients in their wound healing journey. So this is the way it works. So using a video camera on a smartphone, the nurses will scan the wound. You'll see here in some of the images that we've got circular stickers. So we place them either side of the wound, and it just helps to make the right lighting adjustments for the image. Then a video recording is taken with the scan to build that 3D image of the wound, which then gets sent to a central portal. So we get an image of the wound, but then we also get a video recording. The clinician can then start to put the details of the wound into the app, the location, the type of wound, for example. And then, as I said, that's uploaded to a central portal, and a PDF document can be created and attached to the patient record. And again, that starts to build that digital journey of the wound. We're actually in the process at the moment of working with the Healthy IO company to try and integrate the portal, the Healthy IO tool, into our single patient record unit, which is System 1, to try and upload that photo directly into that patient's record. And of course, that is only going to improve nursing time and delay that photo obviously being uploaded to the system. So now we're going to touch on some of the key benefits. So the margins for error of traditional manual wound measurements are more than 40%. And you can see here, 3 measurements have been recorded for the same wound. And this could show that the surface area of the wound is reducing, but actually the wound is unchanged and stagnating. So the app improves this. So by dragging a line along the length and the width of the wound, the system will then identify the exact parameter of the area. So this calculates a much more accurate surface area, and that margin for error falls then less than 3%. So moving on to benefit 2. So having that centralized access to wound data allows us to see our caseloads and see when assessments haven't been completed, when photos perhaps haven't recorded, and prompt our clinicians to do that. It also alerts us to those stagnating wounds on our caseloads, which the clinicians can then review, and it prompts them to do an early an early review of that treatment pathway. So as I said previously, a report can be generated into a PDF document and attached to the patient record. But it becomes particularly valuable again when referring to specialist services. So when we're referring a patient to the vascular department or dermatology or to our tissue viability service, it strengthens that communication and promotes that collaborative working, which of course can only improve those healing rates and patient outcomes. I find that in the NHS, where that service pressure is only increasing and continuity of care becomes a daily issue, anything that can prompt the nurses to review that treatment pathway at an earlier stage is only going to be of great value to us. So at the start of the project, as you can imagine, there was concerns. You know, we had clinicians saying, how am I going to have the time to use this new piece of technology when we're so busy? We had staff out there that are just not confident in using new technology. We had some questions suggesting, what is an app? They just didn't know what an app was. I mean, we can laugh about these things, but these are real concerns that we faced at the start of their journey. And there are staff members and clinicians working out there that are just not confident with with new technology. So what we did is we decided to do a weekly staff survey. So we sent out the staff survey, and we wanted to monitor staff confidence, and we wanted to measure effectiveness. So we collated the results of 137 of these questionnaires, and we found that confidence just after 1 week of using the app was 7 out of 10. And by week 16, this had reached a score of 10 out of 10 for confidence. We also found that after just 4 weeks of using the app, 60% of staff reported that the app promoted early detection of static wounds. And by the 12th week, 100% of staff felt that this app really supported that promotion of early detection of the static wounds. I was really surprised by that, just to see that confidence in such a small space of time, reaching those scores when they'd had those initial concerns. It leads on to benefit 3. And as we said before, from the other speakers, one of the most important factors is that patient involvement and that patient voice in the patient's wound care. Questionnaire, and we've collated 173 questionnaires that have come back, and that's over a period of October last year to the present day. And actually 100% of patients said that it helped them engage in their wound care journey, in their wound healing. And 94.5% of patients said the app actually had a positive effect on their well-being, which again is so important from what Jenny was saying earlier about mental health. So what I'd like to do now, if it's okay with you, is to show you a short video. So the video is one of our leg ulcer patients, Roger, who's really pleased to be a part of that, to be a part of this, and one of our leg ulcer clinic nurses, Heidi. We just wanted to share their experiences on what they thought were the key benefits on using this app in practice. So we'll have a look at that now.
I'm a wound clinic nurse and I work for Leicestershire Partnership Trust.
Hello, my name's Adelie. I'm a wound clinic nurse and I work for Leicestershire Partnership.
To the wound clinic, we've started a new dressing with him, and using the Healthy IO, we can track his progress with his wounds.
From my point of view, it seems a great app to use. You can keep continuity of the patient's ulcer. You can bring up previous records and you can see the progression of the ulcer. So it all adds to the continuity of the treatment of the ulcer.
One of my key benefits of using the app, I think, would be the measurement of the wound. It calculates the area of the wound, and then you can check that over time. We check it weekly and we're able to see if there's any progress with the wound or any deterioration, and it alerts us a bit quicker. In that respect, it's improved my practice because I'm constantly reviewing the patient's wound and seeing if there's anything that I can change within their care plan to benefit the patient. I'd just like to say thank you for listening to me today, and thank you to Roger again for sharing his experience. That's it.
Okay, thank you for that. I can't tell you how thrilled our leg ulcer patient Roger was to be a part of that and to involve him in that process. He was over the moon. So just to summarise briefly before I go over time, is just to say...
Too late, Laura.
Pardon? Oh gosh, okay. No, I'll leave it then. Just to summarise, obviously you can see the benefits.
Summarise, carry on, go on.
Oh, sorry. So, using the Healthy IO app has allowed us to consider whether these traditional measurements of wound management need addressing to ensure accuracy, prompt evaluation of treatment pathways, and improve patient engagement as we empower them to be obviously more independent in their wound care. So thank you for listening. I do apologise for going over, and obviously any questions that you have, I welcome.
Laura, thank you. extremely interesting presentation. It's created a wealth of questions. So if you can do me a favour and start looking in the chat box. Thank you to John, who's answering the technical questions that people are putting in. But I just want to ask you one from Adelie. Are your community nurses using the Healthy.io app in patients' homes? If so, how easy do they find it?
Not at the moment in patient homes. We started the trial in the wound care clinics, and then we did branch out in the last month to our tissue viability nurses, who do obviously visit patients in their own home. So currently we're working with Healthy.io to address some of the issues like circumferential wounds, multiple wounds, and everything like that, to try and make it a lot more effective in practice with some of those complex wounds.
And I just put one in because this has been asked a number of times. Are you starting to see any impact on healing rates?
Oh, massively. I mean, we developed a process for reviewing our static wounds and giving time out for nurses to actually do a deep dive of those patient records and see what was going on with them. And we had 60 static wounds in January. We worked through that as a bit of a study, a PDSA cycle, and actually that reduced by 21 wounds by the end of March. So it had made that difference from the wounds no longer being static. So yes, absolutely seeing a difference.
So there is a question in the box, and I am going to move on now, Laura. There is a question in the box around have you published, and if you've got some data behind that, that'd be helpful for us to connect with you. If you have got to publish or you are going to publish them stats, that'd be really interesting information for the likes of us and Julian particularly. It'd be useful for us to see that. But I can't thank you enough, Laura. Very, very interesting presentation. Please look at the questions in the chat box, because there's numerous ones that probably only you can answer, if that's okay. So I'll move us forward now. So Laura, great big thanks. Our final speaker is Dr. Yoona Adelie, National Wound Care Strategy Programme Director. Well, it says for the HSN network. However, she does work for NHS England, NHS Improvement, in reference to heading up this programme with myself and others in the team. And she's done so much great work in this field in spite of the pandemic. So I'll hand over to Yoona, who will now give us a presentation around the National Wound Care Strategy Programme.
Hello, thank you, Margaret. I'm just going to hope that I can't see a next button, so I'm going to press something and hope that it moves. Aha, somebody's done it for me. Wonderful, thank you. So I'm hoping everybody who's dialed in is actually aware of the National Wound Care Strategy Programme, because you obviously have an interest in this topic. And you'll be aware that our purpose is to scope the development of a wound care national strategy for England that focuses on pressure ulcers, lower limb ulcers and surgical wounds. And we're working out how to make the case for change, what needs to happen and how to make it happen. So that's our aims. Today I'm going to be focusing on data and digital, because that's what I've been asked to focus on. So I hope that makes sense. That's not to say that the rest of it isn't very, very important, because it is. So next slide, please. As has already been outlined by Julian, we know that there is unwarranted variation. And what we mean by this is we always expect care will vary per patient, because people are individuals and they need to be. But we should generally see very similar things happening for patients with very similar types of wounds. For example, if someone's got a venous leg ulcer, we expect most patients with a venous leg ulcer to be in some form of compression. But what we are aware of is that there is underuse of evidence-based care, and compression particularly springs to mind with this, and overuse of intervention for which the evidence base is extremely weak, for which I'm looking at the over-reliance on dressings, for which there is very little evidence that dressings make much difference. Other treatments, we need to treat the underlying cause. So we've got a problem with unwarranted variation. We've got a problem with poorly organised care. And again, I'm not criticising individuals, but we have come to the conclusion, I think as Julian alluded to at the beginning, the problem is with the system. And even when people want to do the right thing, the clinicians want to do the right thing, it can be very, very difficult for them to do so. I've got a number of ex-colleagues, friends who were damn good district nurses. They know what to do, but they're now working within general practice where they get a 10-minute slot and they can't actually do what they know needs to do. So poorly organised care. But underpinning all this, we have a horrendous lack of data and information to inform quality improvement. Julian's had to do his work from modelling data, and as Julian himself will say, we know there's big uncertainties in that data. We've all done the best we can with what we've got, but actually we know that the data is in desperate need of improvement. But as Julian has demonstrated, what we do know is that there is a huge demand for wound care and a huge need for wound care, and it is rapidly growing. We have to do something about this. Next slide, please. So what is the purpose of data? Well, data serves quite a lot of different purposes. We use data both for our clinical, to inform our clinical practice, but we also need it for our business needs so we can make good decisions about commissioning and contracts and performance management and all that side of things. And so there's all different types of data we use. There's the patient data, the demographics, what's wrong with the patient, what do they need, how often are we seeing them. There's workforce data, who are the staff involved, are they the right staff? And there's also product data. And we know that we have got issues with all these areas of data within patient care. I think we've probably managed to get their names and ages right, and hopefully their gender, but the rest of it, frankly, could be greatly improved. Next slide, please. Now, we are working from the principle that data collection must be secondary to operational practice. And what we mean by this is we don't believe in this day and age anybody has got time to go around and do paper audits or even electronic audits on what is happening. What we need is clinicians at the point of care. As they make their notes or as they take an image of a wound, this automatically goes into a system, and the data needs can be drawn from that system, out of that original clinician. So you haven't got people having to enter data in lots of different places. If you get it right, it can then be used for all those different needs that I outlined on the slide above. So we thought we'd just do a little poll, if that's all right with you, to find out what people on the call are doing. So I've got 3 questions here. When I say, do you handwrite clinical notes, I'm meaning, is that your primary way of taking clinical notes? Because obviously everybody handwrites something occasionally. But do you handwrite your clinical notes, or do you put them onto a desk computer or laptop, or do you enter on a handheld device? And I just wonder if we could just take a few seconds just to answer those questions. And I learned that I'm the only one who can apparently see your answers. So if you can just quickly put something in, I'll just be patient. We'll give 10 seconds to see what's coming up. It's all wiggling around. But it looks, oh, hang on, a few more coming in now. I was about to make a conclusion. Okay. It looks as though over a third of you are still using primarily a paper system. About half are using a desktop or laptop, and only 14% are using a handheld device. So we would like to see a world where, frankly, most of us are moving to a handheld device, certainly out in the community, because that's what you need. Nobody wants to be lugging a desk computer around with them or a laptop. So thank you. Thank you for giving us that information. Right, next slide, please. Now, I've posted the link to this already into the chat box, though I think it's also there under, would it be files? I think it's been put in. This is the recommendations for implementing the National Wound Care Strategy Programme lower limb recommendations on one page in brief. Now, what we've got here, first thing is the model of care provision. We strongly believe we have got to move care to dedicated services staffed by clinicians with the appropriate time, knowledge and skills and referral routes to deliver the appropriate care. And we see this as requiring rollout of dedicated chronic lower limb wound care services, probably primarily clinic-based, but also being able to do home visits for those people who need it. And we need the educational materials to do that. But alongside this, and just as important, is we desperately need improvements in data and information. And we need to roll out what we're calling point of care, NHS compliant mobile digital technology, of which the Healthy IO is one example. It's a very good example. I do have to say it is only one of other products as well. And we do keep a register of all the products we are aware of on the National Wound Care Strategy Programme website. So please, if this is something that interests you, go and have a look. And not only will you find a list, you'll find the contact details for the companies that we are aware of who are doing work in this area, which I hope you'll find useful. Just to say, because I'm looking at a lot of the questions that were rolling in, and I don't know if you've picked up on this, we are also developing like national standards for what these products should be capable of, which will answer an awful lot of the questions that you've posted on the chat. These are still in draft form at the moment, but they are getting close, and we are working very closely in partnership with companies, suppliers that produce these products, to make sure we're realistic in our ask, but also to make sure we're not under ambitious in what we're asking. So we see these type of systems as being absolutely essential. And we believe that if we can do this, we should then be developing towards the delivery of evidence-based care, which is more likely to improve wound healing, reduce the burden of wounds, and reduce the cost of caring for those wounds. Right, next slide, please. Now, to do this, it is not straightforward. And so what we have decided to do is to recruit 7 first tranche implementation sites, one from each of the NHS England regions in the country, to start working intensively with, to do this deep dive work, to actually work out how we develop a blueprint for implementing nationally. And you may have seen that recently we did a recruitment for the first 4. Well, we were actually aiming for 3, but we ended up with 4 because we managed to squeeze the money somehow to be able to afford 4. So we will be working with Hull, the Hull area. So it's both hospital and community. Hospital, community and primary care, I should say, for all of these. Manchester Foundation Trust area, the Wye Valley area, and Kent Community as well. But we didn't just ask for one organisation. These organisations that we are going to be working with all came as a team and with their partner organisations, because we recognise this isn't something that can be solved in hospital or community or primary care. We all need to start working together. That's the only way we're going to get forward. So that's the first 4. And then if you could move on to the next slide, we are just starting And what we asked for from these sites was, we asked for a commitment of readiness to implement our recommendations. We asked for them to be willing to work with us to develop an implementation case. They needed to have full support from all the partners they will be working with. They've got to be willing to take on a recognised service improvement programme management methodology. They've got to allow their staff to undertake education and training. They've got to implement digital tools, which is what we're talking about today, actively engage service users, address health inequalities, and work with us as a bigger team to develop this blueprint I talked about. And for this, we have funded them with a project manager and some admin support to get this started. We know that will not be enough, but we are very optimistic that within 12 months, they will be making such savings that they will have more than paid for the cost of what they're doing. So this is what these people have signed up for. Next slide, please. Thank you. And what I was going to say was, we are now starting recruitment for the second wave, and we will be seeking a site in each of London, East of England, and the Southwest. So if this is something that excites you and you'd like to get involved, please have a look on our website, because you'll start to find the information. I think we opened recruitment in May, but we thought it might be helpful to give you some early information. Now, we also had a bit of a windfall, because NHSX heard what we were up to and were impressed with our work. And so they approached us with the offer of some additional funding in order to really drive the digital work forward. So with this funding, we're going to be recruiting a digital and data program manager to work with our central team, but also we'll be able to give each of these sites a regional digital and data project manager. So all our first tranche implementation sites will not only have a project manager to drive the clinical work and the joined upness, but also a digital and data project manager. And we are hopeful that these teams, working with ourselves, will be able to pull together a blueprint to support other people who wish to make this change. And I say wish, but actually the way things are going, I think it is likely that there is going to be a policy drive from very high up to make sure this happens. Next slide, please. Other digital work that we've been doing, as I mentioned, we've got the register of known suppliers of wound management digital systems. And yes, of course, Healthy.io are on there because they're one of the key players in the market. We're also developing standards to inform the procurement of wound management digital systems. So if you're an organisation that wants to go out and start looking at which company you're going to work with, which supplier, we're trying to provide you with some standards to helpfully, you haven't got to start from a blank page. You can use these to inform your procurement procedure. We're also promoting digital wound imaging as part of standard care. These digital imaging has been around for years now. For goodness sake, it needs to be part of standard care. Telemedicine for wound care. We believe that, a lot can be done over telemedicine. And of course, we've also got the online education resources, which I hope will be a godsend to those of you who are responsible for educating your clinicians and people in wound care. So those are now free to access online, and all this can be found on the National Wound Care website. Next slide, please. And I just wanted to end up with somebody sent me back to the handbook for the NHS Constitution for England. And I went through the whole thing, but there's numerous pledges and promises in this, but the one that really caught my eye about digital and data is the NHS pledges to ensure that those involved in your care have access to your health information. We cannot do this unless we embrace digitalisation. This has to be the way forward. And that's where I'd like to end, please. The last slide. It's just if there's any questions. Thank you.
Una, there's lots of questions coming through, and can I just thank you for a very informative presentation. I think Louis has presented good questions around, well, particularly the lack of RCT type evidence, quality evidence around wound care, but put a question in that. I think John helpfully provided some assurance on that, but that's on in terms of the LTIO, in terms of its standard mark, which it does have. The question for me then is, and this links back to Julian's early work in 1213, what were very obvious on, and Julian, I'm not going to speak for your research, but some of the take-home messages that were very loud and clear from that work was wounds weren't even being assessed. They weren't being described on the assessment where the wound was. So the woeful data around how wounds were being described, never mind assessed, never mind then put into categories of effective wound management strategies. So the one linked to the other, And one of the things that we absolutely do not have any evidence about, or even tools until we move into the digital space, is how do we capture wound healing rates? And that came very clearly from Julian's early work. And I think, if nothing else, we standardised wound assessments. We got consensus nationally around how we should be assessing wounds, all wounds, and then specialised in some areas like lower limbs that will need Dopplers, etc., etc. And we also, so we put sequins into the system to try and standardise that. We also recognise that we have to do something around wound healing, around training and education, etc., etc. And this is where we moved into very quickly how the digital space could help us significantly in terms of time for care, releasing time for care, because one of the things that's become very obvious is digital technology helps release us time for care and moves us away from what often is double counting or erroneous methods of measuring and assessing wounds. So there's some logic in this, that if we can assess the wounds correctly, we're probably going to get a better chance of putting effective management plans together, and therefore the nature of that should result in better healing rates. But we're being rubbish at collecting or having the tools to help us collect healing rates in the first instance. It's crude. We've got a wound, and 12 months, 18 months, 3 years later, we might have got the wound healed. Well, what's happening in the middle? We just don't capture that information. So I think we've a long, long way to go on the national strategy. Una, there is some questions in the box for you, but we've come into a position that we've got a couple of minutes probably just before we run out of time, maybe 1 minute, and then I need to close. So maybe the question that may be worth asking is around digital innovation starting to come through clearly in the national strategy, and how do we think that'll standardise wound care? Now, it might seem an obvious question, Yoona, but it's a fundamental question, isn't it, in terms of our strategy and moving forward?
I don't think it's about digital innovation standardised wound care. I think what we need to be doing is working out what are the standards for wound care and how do we apply digitalisation to that.
Yes.
So, and that's exactly what the first tranche implementation site teams are going to be doing, is we need to be coming up with coding systems that we all use, and we all use the same codes. At the moment, I was told the other day, I think you were in the same meeting, weren't you, Julian? 2,000 snowbed codes for wounds. Well, how on earth do you find your way through 2,000 snowbed codes? It's ridiculous. So we can't change the SNOMED codes, but what we can do is direct which ones should be used. If we all start using the same things, we stop counting not just apples and pears, but apples, oranges, bananas, kiwi fruit, and all the rest of it. So let's try and make sure that we standardize what we've got and we use it better. And that's what we need to be doing. And then we apply the digital technology to help us do that.
Thank you, Yoona. There are rules asking for the passcode to open Professor Julian Guest's slides. So if somebody can help on that for me in the chat box, because we're just about out of time. There's people asking for emails, address, etc., etc. If you can keep an eye on the chat box. We will come back to everybody. We promise that the speakers will answer the questions we've not really been able to get to, and we'll collect all of those and come back to everybody on it. The key message from me as the SRO for the National Wound Care Strategy work is please get involved. Digital innovation in this field is essential for the success of the programme. I can say it's a key area that we will be focusing on. I can only thank all you speakers for 4 brilliant presentations, from the patient perspective to the technology, to the evidence through Julia, and now from Yoona in reference to the National Wound Care Strategy and where we're trying to play this field. The standards around digital technology is in a place that we're expecting to publish them soon, Yoona, I understand. They will be out.
Yes, hopefully in the next month or two. Yes, they're well on the way. Yes, well on the way. They've been in consultation. Right.
So I think I'm just about up on time. Is that right, team? So I'm not going to pick any more questions for people. I promise we'll get back to everybody afterwards. And it has been recorded. It'll be available to you post the event. So please take the opportunity if you need to come back to that. And we'll come back to you all. Please get involved. That is my last message. I'm just checking. I keep getting texts from people. Yeah, right. Okay. Thank you. So I'm going to close the event now. Thank you very much, everyone, for your contribution. And I hope you found it interesting and informative. Thank you.